factors are actually biological agents, infections, and the commonest of these are actually viruses. But there are also genetic defects that might be inherited. Someone may inherit a genetic mutation that puts them at risk of developing cancer later in life. And I want you to note I'm saying developing cancer, not catching cancer from someone, because people develop cancers. They don't catch cancer from other people who have cancer. And at Uganda Cancer Institute, we are not, scarce of people who abandon patients because they fear they will catch cancer when they stay in a cancer ward for a long time. I also think it's very, very important for us to appreciate the picture of the burden of cancer in this country. I don't know whether there is a pointer here. Is there a pointer? Yes. When you look on our left, those are the commonest cancers in men. And I want you to note that part of the pie that is green, that is prostate cancer. It's the #1 cancer in men. And the next cancer in men is Kaposi's sarcoma. Now, Kaposi's sarcoma is not a cancer that many people relate with, but it's actually the second commonest in men. And the third commonest is cancer of the esophagus. Now, many people actually never think about this, but I want to let you know that kokolo yo mumiro, yo kokolo yo kusatu, mu Uganda, mu basajja. And then the fourth is non-Hodgkin's lymphoma, and the fifth is liver cancer. Now, I will just rush and go to women. Cancer of the cervix takes almost 40% of all cancers in our women. Actually, as a matter of fact, it's 37% of all cancers in women are cancers of the cervix. And the next big portion is breast cancer. When you look at that pie chart, the two cancers account for almost a half of all cancers in women. And I think it's important for us to note that. And I'll just move on. Now, I also wanted to emphasize that one of the things that we talk about at an individual basis is actually cancer screening. Now, in this part of the world, we want to do what we call cancer early detection, but we use the word screening because it's what rhymes with, majority of the people. Now, why we emphasize cancer screening is because of those multiple risk factors. We cannot make a person's risk to suffer from cancer zero. And so everyone remains at risk of suffering from cancer. And therefore, I want to tell everyone in this room that we must, as part of our lifestyle, do cancer screening. And don't ask me at what age. Everyone needs to be checked up for cancer, including children. Because we can actually identify retinoblastoma in children when they are being immunized. And that's the best time to identify it. What cancers can we screen for? Now, cancer of the cervix is #1, prostate cancer, breast cancer, cancer of the bowel, large intestines. Malignant melanoma, actually, we can screen for it. When we are seeing patients in our clinics, we can examine them for lesions that can be malignant melanoma. But also ovarian cancer, we can make an effort to catch it early. Now, I emphasize this, that all anyone needs to do is go to a health worker and the right advice will be given to that person. We shouldn't wait until when we are sick. But I want to paint this picture because I know there are many health workers here that we do not do cancer diagnosis by a blood test, not by, tumor markers. All cancer diagnosis must be done by tissue diagnosis. We take off a biopsy and, take it to the lab and we confirm cancer. These tests can give us a sense there may be cancer in this body, but they cannot help us confirm that a person has cancer. And I thought that is important because it's not uncommon for us to have somebody with a battery of tumor markers and they say they have told me, these are cancer cells in my body. Now, I want again to paint a picture of cancer treatment, and I think this but I want to go to last bullet, targeted therapies. In this era, we want to personalize cancer treatment, And one of the things we do is what we call targeted therapy. Now, why I highlight this is that targeted therapy depends a lot on the entire process of managing this patient with cancer. If you harvest the tissue wrongly, you process it wrongly, you preserve it wrongly, we are not likely to do tests that are going to benefit us in determining what targeted therapy this patient needs. What am I saying? If you were harvesting a tissue from a breast mass and you harvest it, you put it in a kidney dish, and you first finish up the surgery, you know, the cold ischemia time that this tissue is subjected to becomes long, and the receptors are likely to be destroyed. So when we take this tissue to Dr. Navada, she will come and tell us, you know, immunohistochemistry is negative, yet it's actually positive. And so what I'm saying is that if we are health workers out there, we should practice our practices to the dot. There are many doctors who harvest tissue, put it on a windowsill, and they remember the next day to, you know, take it to the lab, even when it's not in formalin. So it's important that we know that when we are doing our practices, we should make sure we follow the rules of the game the way we should. And I want to emphasize this again. There are many health workers out there with people who have survived cancer. I may never remind them that once treated for cancer, you have to undergo what we call long-term follow-up or surveillance. We survey this body of a survivor for the cancer coming back or another cancer showing up. Now let's go through briefly how to reduce risk factors for cancer, because I mentioned that cancer, the cause is multifactorial. This table shows us the risk factors in this country. Alcohol is number one. We lead the region in consuming alcohol. And then tobacco use. These are risk factors that we can actually address. Overweight. Actually, overweight is quite high. It's about 18% in Kampala. And you don't want to be one of those. Then healthy diet. Fruits and vegetables are critical for us in our diet. Physical inactivity. Many of us, God has blessed us, we move while seated, and we never have time to do exercise. And then there are those infections, hepatitis B, HIV, H. pylori is very common. And there are many people moving around treating my ulcers. That H. pylori needs to be eradicated. And I think our colleague from Barara was showing us herbal preparations that actually can deal with many of these infections very, very easily. Now, I want to paint a picture. The distribution of these risk factors actually causes the distribution of cancers in the country very, very different. And I showed this picture to tell you that actually there's a study we have done, and we've confirmed that the cancer burden across the country is not uniform. For instance, liver cancer is number one in the Karamoja region, while prostate in men, while prostate cancer is the top cancer across the country in other regions. And that tells you that even within the country, we need to know the risk patterns across the country and also the cancer burden patterns across the country. And for the Ministry of Health and for all of us, we need to know that our interventions should be targeted according to the risk pattern. Another surprising finding was that cancer of the esophagus is actually number one in West Nile, and prostate cancer is number two. That emphasizes the fact that the way we live our lives actually determines the cancers that we are likely to develop, because West Nile is well known for tobacco growing and tobacco consumption. Now, what do we mean by healthy eating, friends? We should make sure we increase the fruits and vegetables in our diet, and the Uganda nutritional guidelines emphasize that at every meal, you should have a fruit, you should have a vegetable. You should have juice and or water. So we should make sure half of our plate all the time is vegetables, and the carbohydrates and the meats take the rest of the half. And I want to say this with emphasis. When you go to serve at this conference, you should make sure half is cabbage, broccoli, beetroot, and the rest is, what we usually eat and we call food, including matoke, by the way. I know there are many people from the central. And then let's do physical activities, including gardening. I emphasize this gardening because it's something that we can all do. We can all do at no cost. Gardening for 2 hours has shown to reduce lung cancer risk by 30%. I don't know how many of us do gardening. But also when we are raising our children, in Kampala, people study in storage buildings. Let's make sure our children are involved in competitive sports because it will encourage them to live a lifestyle that encourages them to do exercise. Now, I wanted to paint a picture on alcohol that the risk of breast cancer is directly proportional to the quantity of alcohol an individual consumes. Yes, this is hard evidence. So the more alcohol, the more the risk for breast cancer. Now this is, now there are many people who are doing hormone replacement therapy, and this increases the risk for breast cancer very, very strongly. Women who don't want to get young and they want to, there are other alternatives, and when you visit us, we can, tell you what you can do, but do not, go for hormone replacement therapy. Let me paint a picture of prostate cancer risk factors. If you can pay attention to the slide, prostate cancer diet is a strong, strong risk factor. We encourage you reduce the red meat, all the fatty foods and dairy products. Reduce those as much as you can. And my friends from Barara, this milk really, take it in moderation. Increase fruits and vegetables. Do exercise and maintain a healthy body weight. Make sure you avoid obesity. Of course, there is still an area of study, STDs, prostatitis, but there's no hard evidence that shows that those increase the risk for prostate cancer. And how do we do prostate cancer screening? We encourage you to start at the age of 40. Starting at the age of 40, let's all know the state of our prostate. And screening for prostate cancer is not difficult. We do ultrasound scan, digital rate exam, we can do MRI and these other things, but at any health facility, actually, you can do prostate cancer checkup. All you need is a qualified health worker, and men can be checked for prostate cancer. Cervical cancer, we should make sure that we vaccinate all our girls against cervical cancer. But I want to emphasize that screening for cervical cancer is actually for prevention, not for early detection. Because we can detect precancer lesions, we treat them and cure them, and make sure that this lesion does not progress to cancer. That's why we emphasize regular screening to prevent cervical cancer. Now, I want to say something about breast cancer, and I want to tell you that breasts have a tail that goes to the armpit. So when we tell women and men to do breast self-exam, I want to remind you, always check your armpit, because many breasts have an axillary tail that actually goes to the armpit. But I also want to tell you that many breasts are different sizes, and that's normal. There are many people who come to the cancer screening clinic and say, my breasts are different sizes. Is this cancer? Of course, women who are here and you have breasts that are bigger than ours, this is obvious. But these are signs and symptoms of breast cancer. A lump in the breast, especially if it's in one breast, a lump in the armpit, or a change in the breast size that is sudden, a dimpling on the breast skin, that can be a sign of breast cancer, or a nipple inversion, and I'll show you a photo that shows this. But also a spontaneous nipple discharge, especially if it's blood-stained or brown in color. I want to emphasize that pain is never an early sign for cancer, and therefore breast pain is never an early sign for breast cancer. It is going to show up, but when the cancer is advanced. And these are pictures of breast cancer signs and symptoms, and you can, for a moment that you look at them. Now, how do we do breast cancer early detection? Number one, you can actually detect breast cancer by yourself, by self-breast exam. You don't have to go to the clinic. Many of the patients that have survived breast cancer or presented early have detected the masses themselves. And then You go to a healthcare provider, and we recommend this you even do annually as you do other checkups. So health workers who are here, don't allow a woman or a man to leave your consultation room without examining their breasts. Consider it a crime. You know, at least if you're in a rush, ask them to check their breasts on a regular basis. For men, we recommend once every month, 5 to 10 days after your day one of your period. If your day one is today, which is Tuesday, maybe the best day is next week on Tuesday. Take a good amount of time and explore your breasts. Then we do imaging, ultrasound scan, mammography, or CT scan, or MRI. But I want to tell you that ultrasound scan is sensitive enough to identify a breast lesion that is likely to be breast cancer. So there's no excuse that we have no MRI. Even at Health Center 4, you can actually examine breasts. And if you think there is something, send a patient to the sonographer to do ultrasound scan. And then surgery plays a role. That's how we harvest the tissue. And I said every time we harvest breast tissues, we should watch out for cold ischemia time. We recommend you pick it, put it in formalin, so that the cold ischemia time is maybe 5 seconds or even 0 seconds, if there is anything like that. Then when we send the tissue to the lab, you know, to Dr. Navada's department, whatever, you know, the results they give us will be exactly what there is. Now, I thought of showing you pictures, but I think because of time, we'll just flash them. Now, I put this picture of a malignant melanoma because many people miss this in the clinics. But if somebody develops a dark patch or a dark swelling on their foot, on their hand, on their skin, and it's new, you need to be keen. If it's there, check what it is. This is a cancer that is very easy to treat if it's early, but very, very, very risky and very difficult to treat when it has spread even to the local lymph nodes. Now, I put these pictures to emphasize to you and everyone that cancer treatment capacity in this country is super good. Should I say that again? We can treat a man with early prostate cancer without surgery and cure them. And we have very many examples. We preserve their sexual function 80% of the time. So this is the time actually to go for cancer checkup, and it's time for the ministry to support, you know, integration of cancer early detection interventions. Now that is a linear accelerator, but we are not looking at that. Take home. Let's watch our diet. Let's go and revise our diet. All of us, let's go and revise our diet. You know, deal with their addictions to sugar, to meat. There are people who, when they don't eat meat in 2 days, they haven't eaten. Now, be physically active. Even if your job is to sit down and do work, make sure you are able to jog at least 40 minutes 4 times a week, or even 1 hour 4 times a week, at whatever time of the day. You don't listen to the stories, better in the morning, better in any time of the day. Physical activity is physical activity. Avoid alcohol. You can reduce until when you stop. You know, regular screening, do medical checkups regularly, because I can tell you, all of us are at risk. And that is the tool that we have to safeguard ourselves. And then I want to emphasize this: seek proper health care with every complaint. There are many quack practitioners that actually cancer will advance in front of them, and they don't even send this patient to the center that it can do the needful. And then when there is cancer, remember, all cancers at all stages can be treated. And cancer can actually be cured. I want to say that again. There are many patients whom we have treated for cancer, and 20 years down the road, they are alive and well, no trace of cancer in their bodies. So thank you very much for listening to me. I'll be glad to answer any questions.
Let's give a big clap to Dr. Noleb, please. He has managed to talk about cancers in the shortest time I've ever seen. Otherwise, whenever we are talking about cancers, it's a whole day, 2 days, and we never finish. Now allow me to invite Dr. Rumu William. Dr. Rumu William is my classmate from senior 5, 6 in the SMAC and medical school. We even sat in the same cubicle. same cubicle. And we are code should complete.
All right. Yes, yeah, with all protocol observed, good afternoon, everyone. It's quite difficult to talk to people when they are tired, and also talking after a very powerful orator, Dr. Noleb. When you talk, when you talk about cancer, it is very, when you make the diagnosis to the patient, you are sad, everybody is sad, but it makes the subject very interesting when he talks about cancer. I saw everybody was sort of engrossed with what he was talking about. But let me try to give this talk. I'm trying to paint a picture of diabetes in Uganda from the local researches we've done, because the theme is taking action. So we need to know where we are so that we can take proper action. Now, diabetes is a chronic disorder of multiple etiologies, meaning that a number of issues that cause it, characterized by chronic hyperglycemia, disturbances in carbohydrate, fat, and protein metabolism, resulting from defects of insulin secretion, insulin action, or both. That is a very old definition, but it is still very useful to us as it touches on a number of issues that occur in diabetes. Now, the diabetes burden, as we speak now, in 2025, more than 500 million people have diabetes, and this number is projected to increase to 643 in 2030 and 800 million people in 2050. In Africa, about 25 million people have diabetes as we speak, and the most sad thing is that 18 million are undiagnosed. You could be in this room when you actually have diabetes when you don't know. And this number is projected to increase by 142% to 59 million in 2050. What about home here? In 2014, through the STEP survey, we had about 600,000 people with diabetes, and this number increased to 1.5 million in 2023 by the STEP survey, which was done by Professor Bahendeka. Again, 50% of these are undiagnosed. So that's important to us as we speak about diabetes today. And again, the person who suffers from diabetes leads a very unpleasant journey. He has a lot of disabilities. You have burning feet. After a meal this afternoon, your feet are burning. You have itching, numbness, pins, and needles. And this is quite disabling. The cost of medicine is very exorbitant. You have stigma. If you're a young person in your 20s, and if your fiancé discovers that you have diabetes, there are a number of explanations to do. We've seen patients going off their insulin. These are university students. They have a party, but just doesn't take the insulin at 7 p.m. when the party is about to start for fear of hypos and collapsing on the dance floor. Unemployment is another. We have patients also having issues with the transport, discrimination, so many other things. Really unpleasant journey. Why should we mind about diabetes? Senabria is here, is going to take us through the heart. It's one of the causes of coronary heart disease, lower limb amputations. Many of our people have lost limbs due to diabetes. It causes blindness through cataracts and retinopathies, erectile dysfunction. In fact, in a study which I did in Mlago, I found that actually many men who were diagnosed with diabetes had presented with impotence 5 years before the diagnosis of diabetes was made. So any person with diabetes, either impotence, should be taken seriously. It causes stroke and cognitive impairment and chronic kidney disease. Of course, I can't talk about that. When my brother Robert is around, he's going to talk us through that. Now, I'm giving you what has been done. I can't start without talking about the risk factors. The NCD's risk factor survey of 2023, 8.3 people are smoking currently. and the mean number of sticks taken per day is about 3 sticks, and the use of manufactured cigarettes. There's so many cigarettes doing the rounds in our city at the percentage of 69.5%. Alcohol, the people are taking alcohol about 31%. That is not a small statistic. And heavy drinking, whereby people take more than 6 drinks. The definition of a drink, which I may not make for purposes of time, that is constituted by about 7.7%. Adding salt, many of us are culpable in this. Every now and then, you're addicted to adding salt, about 17.4%. And many times, we also take it in processed foods at 11, things like crisps. There's a lot of salt in that, and we are very culpable on that. Fruits, he was talking us about fruits. Many of us are very culpable. Of course, I won't ask you today, who of you took a fruit yesterday? I won't ask today because by design and default, a fruit has been served by the hotel. But I mean at your homes. And again, when you look at the mean number of fruit serving per week, is a miserable figure of about 3. Fruit serving per day, about 1. So we're not doing very well when it comes to fruits, despite them being thrown to us. And fruit servings per week or vegetable serving per week, about 3.6 days. Vegetables, we are not doing any better. And even when to take best vegetables, they're just sprinkled. We go to a restaurant, you see vegetables are just sprinkled on the food. We are talking about a huge amount of vegetables on our plates. And those who eat less than 5 fruits or vegetables, can you imagine? The majority of us eat less than 5 fruits or vegetable servings per day. And that's not very good. You've heard what Nolebas advised us to do. Insufficient physical activity, in about 3%, but no physical activity at all. In the majority of us, we do not do any physical activity at all. Overweight, that's one thing, we cannot be overemphasized. The number of cancers which were associated with overweight, and the overweight we're talking about is the central obesity. And you see 23% or 24% of us are overweight. We have a BMI higher than 25 kilograms per meter squared, and obesity is about 9.3%. Hypertension, Senabla is going to talk to us about hypertension. This is, a quarter of us, if you take 100 people, a quarter of the people will have hypertension. And the most saddening thing is that more than 80% of the people are not taking their medications. Diabetes, we're not doing any better. If you look at impaired fasting glucose, about 4.9%, and that has risen. That is the pre-diabetes, and the diabetes prevalence rose from 1.4% to 3.3%. Now, I'm going to take you through a number of some studies that have been done in diabetes, throw more light about diabetes. Many of you have clinics, you've seen patients who are small, they're really lean, their BMI is 23, blood glucose levels are high, very difficult to control with the so-called music of starting patients on metformin. So the gist of this research was to really find out what was happening in newly diagnosed patients, to understand, most especially the lean ones who didn't have any autoimmunity. So in this study, we found that 32% of newly diagnosed diabetic patients were lean. Their BMIs were less than 25 kilograms per meter squared, with a low visceral adiposity. So what does that mean? So this habit of starting them on metformin, do exercise like this, does this still hold water? That's why we are here. So lean diabetes, again, was associated with reduced pancreatic secretory function. Probably these patients may benefit from initiation of insulin right away, other than treating them blanketly with metformin. That study, how do our patients present with the diabetes? That study was done by Dr. Agatha Nambia in 1996, trying to look at how the patients present in Uganda. The mean age at that time was 45, and the majority were hypoglycemic, and 11.9% were presenting with concurrent infection. And if you look at, I don't know how to use this, but if you look at that one, the diagram on your, 2 meters on my right, you see that many patients were polyuric, polydipsic, and had weight loss. In other words, our patients present with overt features of hyperglycemia. Again, they present with complications. They present with neuropathy, hypertension, and impotence comes in again here with our patients. Some of you are busy prescribing tadalafil, Apcalis for your patients. This could be diabetes or even coronary heart disease. Young. Hey, sorry. Then again, we looked at, before we go into the event, there must be something that happens, and this is the risk. So one looked at atherosclerotic cardiovascular risk among patients with diabetes in Uganda. And we did this study in 8 health facilities. Some of them were public health facilities, others were missionary facilities. And what did we find? We found that 65% of our patients are at high atherosclerotic cardiovascular disease risk. Time. All right, let me continue. Now, 7% of these patients were not on lipid-lowering medications. Remember, all patients who have diabetes, if they're 40 years and above, they should be on cholesterol-lowering medicines. But in our patients, only 7% are using this medication. This is not very good. Again, we found that not everybody, in the past, people used to think that every diabetic is at the same cardiovascular disease risk. This is not true. You can have many at different risk factor sort of scores. And 13% of these had a high SVD risk and are not on antiplatelet agents. Again, there's something we shall, I think, discuss it as we speak. The other thing that we looked at was atherogenic index of plasma, which is a surrogate marker for plaque density. If you have your coronaries, what is the sort of fat deposition within the coronaries? And what we found is that more than half of our patients with diabetes have coronary plaque, have atherosclerotic plaques in their coronary arteries. What about other complications? You can see in that meta-analysis by Chibirige, diabetic peripheral neuropathy, 38%, retinopathy, 32%, diabetic nephropathy, 31%. So that means that we need to devise ways of having our health workers screen for these complications, because these complications are highly prevalent among our patients. Now, we cannot just talk about all right, so we cannot just talk about problems all the time. We need also to see how we can handle all these issues. So we also did a cluster randomized trial looking at a nurse-led management intervention on systolic blood pressure among these patients to find out whether such an approach can be of some use. Doctors are never there. They're either attending conferences, and when they are around, they don't have patients for the time for patients. Our nurses are usually available, and this was quite useful when it came to HIV. So in that cluster randomized trial, we based it on a chronic care model where we trained our nurses, we gave them decision aids, we gave them medicine, we gave them decision support, they had a community sort of support, and then if you look at the other on the right, you see you have those components of the intervention. Training, we trained the study nurses, we had a protocol, we gave leaflets to patients, we trained peer leaders among the patients to help mobilize patients. Then we also had text messages, phone calls, etc. And what did we find? We found that actually this intervention after 6 months significantly reduced systolic blood pressure. That was our primary outcome. Reduced it by 13.75, and that was statistically significant. It reduced the systolic blood pressure and the SVD risk. So that's one thing to think about. Task shifting. Can it be of some use in NCD? People in HIV have used it, and it has helped. So as I wind up, what are the implications of this local data in diabetes management in our country? We've of course seen that diabetes is increasing in both urban and rural areas. Risk factors are increasing in both urban and rural areas, and about 50% of patients are undiagnosed. So awareness campaigns and screening for those at risk should be something to think about. Late presentation with fetal complications. Again, we need to have awareness campaigns and screening among people living with diabetes. And we also shown that diabetes mellitus is heterogeneous in causation and SVD risk. So very useful in drafting protocols and guidelines. And in the guideline, we have actually, as Uganda Diabetes Association, we are at advanced stages of having a national guidelines on management of diabetes, and we are cognizant of these findings. Task shifting could be a pragmatic strategy to increase screening and management of diabetes and cardiovascular disease in the community. And of course, I cannot leave this podium without saying that development and dissemination of decision aids, protocols, and guidelines is one thing could be a game changer as we take action to fight NCDs in Uganda. Thank you very much for listening.
Give Dr. Ume a bigger clap. Recently, I learned that there are 5 types of diabetes. I know most of you know 2. 5 types. And today he has talked about one of them, that one for thin people. But I know you know type 1 and type 2, but you should know there are 5 types. So those of you who think are not diabetic, please go and get checked. Secondly, when a diabetes month, actually we commemorate World Diabetes Day every 14th of November. So use this time to renew and check your diabetes status. Let me take this opportunity to invite Dr. Isaac Sinaburia, who is a consultant cardiologist from the Heart Institute, to walk us through hypertension and cardiovascular diseases.
Yes, good evening, everyone. All protocol observed. Please don't doze. Let's not lose you. Yeah, happy to be here. I want to take this opportunity to thank the organizers for giving us the opportunity to share. And I was delegated by my ED to do this work. And I was happy to take it on by one simple reason. Hypertension is an area that I have a lot of interest in. So I changed the topic a bit to look at hypertension as the focus, as I was requested, because they told me to look at the complication. But also I wanted us to look at the opportunities available in order to be able to manage these, not manage, but prevent the complications by making the medicines accessible. So as I go through, I don't want to lose you. That's my main objective. How do we make all Ugandans to access medicines and be managed early? Yes, thank you. Yeah, so as a background, globally, we know that hypertension is the leading cause of cardiovascular diseases. But specifically to Uganda, it's still the same story. Like my colleague has shared, in the recent survey, hypertension actually was still high up there. If you say 1, 2, 3, 4, and you keep repeating it, chances are high that 1 out of the 4 or even more have hypertension in this room. And the way we are clustered Probably there are shared risk factors. So you might find that all the four have hypertension. I'm not scaring you. All I'm saying is check your numbers and we can control those numbers. Take time to be screened. And the reason why you want to do this is because hypertension is associated with complications, which I will share in a slide. And the easier way to win these devastating effects of hypertension is for us to address the entire cascade of care, where we're looking at screening, diagnosis, treatment, and then control, knowing that blood pressure control is the main thing in preventing these complications. So this slide is full of complications, and I will not go into the detail of how they come, but I labored to categorize them. There are those that we call cardiovascular-related complications. Heart failure, it's the end game of all cardiovascular-related things. So include even hypertension. If it's not controlled, the heart will fail. It's like somebody doing weightlifting. Those muscles will become thick, and eventually they will become flabby, and they will not be able to squeeze. You won't be able to generate even a reasonable blood pressure. So some patients, we pick them when their blood pressure is low. But because we are too late in the spectrum, we think it's other things. But as you start to treat them, you realize that their pressure actually starts to come up. And that category, for me, when I see them, I get excited because chances are high that we can reverse the process and be able to give them a chance to life. Coronary artery disease, we're able to correct these things at the Heart Institute, but it comes with a cost, meaning that if we treated hypertension appropriately, you don't need to spend that 7 million to unblock your blood vessel. Aortic dissection, it's many times we lose these patients, especially if it involves the vessel as it leaves the heart, because once it tears, it's an emergency. If the tear is elsewhere along the aorta, then there is some time. But many times, even when we think there is time, access to things that can correct it are a bit out of reach. Hence, we need to prevent these things. Peripheral artery disease, diabetes causes blockages, and then they lose their feet. But also hypertension can cause peripheral artery disease, and supply to the limb is compromised, and we end up removing these limbs. Or in good settings, they can actually put stents to improve the flow. But these are still expensive interventions. Cerebrovascular complications, stroke, hemorrhage, cognitive decline. Many people actually are no longer performing to their full capacity because hypertension has caused something up there. And the problem is it might be a bit hard to reverse when cognitive impairment sets in, because the multiple impacts will affect very pertinent brain areas that will compromise somebody's functioning. And this can commit them to not be able to earn, and therefore they can't even afford basic care. Renal complication, let me not even trespass because my teacher will talk about it ably. But hypertension is one of the risk factors for that. Sight issues, hypertension. That's why when you go to see the ophthalmologist, they want to first check your blood pressure because there are changes. So they end up sending many people back to us to correct that hypertension. And once it's corrected, sometimes sight, if it's done early, it's able to be restored. Erectile dysfunction, I cannot overemphasize that because hypertension is asymptomatic, many times by the time we see people, they have actually these complications. So don't be there to screen using complications. Screen everybody who comes your way for hypertension. And all of us in this room, we should actually check our blood pressure regularly. The risk factors, Dr. Noleb and Dr. Lumu went through them. But you realize that when you look at the risk factors, most of them are called modifiable risk factors. There are only a few that are non-modifiable. Your age, we know people have tried to edit their age, but even if you edit, I'm 44 years, but even if I get to look younger, even if you tell me, oh, Isaac, you are 18, you're lying. You actually evil because you can't change it, right? Gender, people have tried to edit, but you're wasting time. that hormone that defines you, that makes you a man. Anyway, let me not go there, but you get the point, right? So the genetics, the same thing, but those are just a few. I've mentioned 3, but all of you here can actually mention a risk factor that's modifiable. That tells us that we actually have work to do to be able to modify the way we eat, the way we do everything to combat hypertension. So these are just a few slides that are going to show us the trends. From 2016, you know, red means danger. I know you might have political inclinations. Shelf them for now. Just imagine red is danger. So you're going to realize that across the years, Uganda is mapped with too much red. That is too much danger. You see how the red is increasing. And interestingly, let me go back to the 2016. There is, you see the Ginger Highway all the way to, on your way to Kigali. When you map those dots, that's actually along the highway. What this tells us that there are cities across this, that there are lifestyles that we trying to adopt, modifiable risk factors that are actually robbing us. We think we are developing, but actually we are attracting things that are going to rob us of the resources that we are trying to make. So I wanted to make that, and as you look through the maps, you're going to realize that most of the places where the rich are or where resources are, actually they are mapped with a lot of hypertension. This was work that was done by Dr. Chirenga and Katajira. They went across the country to see the burden and how regionally hypertension is playing out. And again, you see that belt, the north is a bit spared. Probably their lifestyle and the modifiable risk factors has not really gotten way out of hand, that they still have lower numbers. But of course, looking at 22% in the north, that's also a problem. So I want to, because the theme is about unified action against communicable and non-communicable, the next slides are going to be talking about the guidelines and essential medicines list. Because the kind of work we do, we realize that there was a time where we were incapacitated. We want to do so much, but our guidelines were limiting us. We want to do so much, but the medicines could not reach these lower centers where the bigger burden is in the communities. And let me skip this for the interest of time. The details are speaking about the 2016 clinical guidelines. And this one was just an extract to show you what was considered to be available at what level then. And you realize that we had atenolol, benadryl, hydralazine, nifedipine, propranolol at the lower centers. And amlodipine was called a specialist drug for regional referral hospitals and higher, which was really a disadvantage to our patients. And I'll tell you why. Because when you're looking at control of non-communicable diseases, the drugs we use, are they available? And access means, is it cheap? Side effects are associated with it. If you have a shareholder in any company that manufactures nifedipine, I'm not against you, but I'll tell you, the reason why people don't adhere to nifedipine is because of side effects. That headache, because it's an asymptomatic disease, right? So if you give me a drug that will cause me a headache, I would not take it. If my legs swell, if my heart is pumping away, in other words, you're pushing me to frequent the hospital because I will have symptoms. And initially, asymptomatic disease turned into a symptomatic entity. So we realized that we needed to strike a balance in there. Effectiveness, I'll share some evidence shortly. Commonly available, like I said, were those drugs. But then we know there are frequent stockouts because we are limited as a country. Inconsistent follow-up. Because of the side effects, people, they give up. Because when they go, they say, you're not swallowing. Then they try to actually swallow. Even they double the dose, but double the dose, more side effects. So they give up. And yet I told you, control will help us avert complications. So you have a population that is not controlled, that has side effects, that also gets complications because they are not controlled. And that can only lead to more expenditure for our patients. So this is some work that was done in one of the HIV settings, because data, sometimes when you want to do information, you want to look at how, so Dr. Kalyesu actually led this paper where they looked at work, I think it was in the IDI, between 2009 and 2013. So in a space of a few years, they found that hypertension had almost doubled. A few years after this work, there's some work that we did in the MJAB clinic, and the focus was to look at the traditional risk factors: diabetes, obesity, lipid, smoking, hypertension. And you could see there that actually there was also like a tripling of numbers between just 5 to 6 years, meaning these risk factors, even in the HIV population, can actually increase when you monitor these patients. Control, the SEARCH trial, IDRC did some work in the western side of the country, and they would screen for hypertension, but also for HIV. For hypertension, they would give people coupons to go to the nearby health facility. But you see, just that intervention, control initial at baseline was 15%. Linking them to a facility, control went to 46%, highlighting the role of linkage to care that can help us achieve some control. This is work that was done in Eastern Uganda. Look at, in these HIV settings, how much are they doing in terms of screening, looking at the cascade of care vis-a-vis the core HIV work. And we saw that in the hypertension screening, we're not doing so well, yet we're doing so well in the HIV side. Let me, this talks about integration and how it can help improve a lot of things, because when you integrate, you're lobbying at multiple fronts. Integration helps that same healthcare provider can actually address many things more than that one thing that you might want to focus on. So these are some of the work. Probably they'll share these slides in the interest of time. So because of the gaps that we had seen in screening, diagnosis, and being able to manage our patients, we use the HATS model, the WHO model that looks at the counseling, the evidence-based protocols, access to medicines, because access was really a big problem, risk, CVD risk management, risk profiling, that patient as they come, you can actually assess risk, team-based care, and then systems for monitoring, because data is the next goal. So we did utilize the findings from this query trial, which demonstrated, Uganda participated, that amlodipine-based regimen actually was superior to non-amlodipine-based regimen in controlling blood pressure. You remember the previous UCG and EML was tagging amlodipine to tertiary care altogether. Yet the bulk of our patients are in the community. So we needed to demonstrate, again, from this work it was demonstrated, but we needed to replay that kind of finding in a setting where nurses are actually doing the screening and the treatment to see if we can actually demonstrate control. So baseline at the MJAP clinic, we mapped out the two cascades of care, the HIV care and the hypertension care. We realized that HIV was doing so well, but for the hypertension, out of the 24% that we picked, only 1% was initiated on medication because they were not available. They would send them to get them from elsewhere, but they were not really available. And because of that, only 15% of those who were initiated were able to be actually, and only 5% were able to be controlled. So you see, it was futile. So many are screened, few are started on medication, and eventually, very few will get controlled. Even those that start medication, because they are on and off and dealing with the side effects that we're talking about. So it was not really possible. So applying that HATS model to make amlodipine being the first drug to use, and then you cascade, if they are not controlled, introduce another drug. If they are not controlled, introduce another drug. One pager that they can pin on their consultation desk, that as they manage these patients, they don't need to open many books, but they can refer to this quick reference that tells you how to start, what to look out for. It was able to actually give us a lot of good results. You see now the two curves kissed each other, that 100% was screened, 100% there was a diagnosis, and then 96, okay, a greater majority were retained in care because the drugs were made available. And in 6 months, we saw jumping from 5.1% control to 75% control in 6 months. That demonstrates that this is actually possible and not much side effects. Of course, adherence was good because we were making the drugs available. We made them available to prove a point, because if they were not available, then many things would be at play. But we got an amazing 75%. Read literature world over. There are few centers, even in the US, where control reaches 72%. WHO actually talks about 50% control. But the funder for this work had to pay us multiple visits to check us out, to say, are these telling the truth? Or this is really, really the truth. So this led us to the journey to say, can we revise the essential medicines list? Can we revise the guidelines to make it possible for our healthcare workers to be able to manage patients? So start with amlodipine, go to the ARB, and the options are listed. Those who have access to UCG, it's there. Up titrate, if no control, bring on a third drug. And that simple approach, many centers are starting to use it. And then, of course, if with 3 drugs you're not getting control, you start to think about referral, such that this can help us decongest the tertiary places. So again, the revision, this is the new UCG that shows normal blood pressure, pre-hypertension. I want to highlight this because many times, because we're talking about prevention, when you look at the data, yes, a quarter have hypertension, but you're going to realize that between 25 and 40% of Ugandans are pre-hypertensive, meaning that that zone, we need to pay attention to it and be able to manage them and control them. So this is how the new UCG looks like, that the starting point is amlodipine. And the level of care, you can observe there, it's health center 3. It was strategic and intentional, such that many people can be able to access these good molecules at their lower levels. Yeah, so that noise should stop now because I'm concluding. So in conclusion, with the rising burden of hypertension and its complications, revision of the EML and guidelines has become a great tool for us to be able to manage many Ugandans. You walk to your facility and find these drugs there. And this is a call to all of you. Please walk to your health facilities because it's a pool system. Tell them that these guidelines have changed. Let them request for these molecules. Can you imagine amlodipine is cheaper than nifedipine? Many of you, I'm sure, didn't know. But let's actually utilize what's available so that we can be able to manage our patients. So this is going to streamline referrals and reduce unnecessary out-of-pocket expenditure. My patients, those who come to the Art Institute, if you ask the transport they use, that transport can actually treat them for like several months if they went to their health facility. You see how we are not being smart? It's a problem. Ultimately, we are going to have better BP control and reduce complications. Thank you so much.
A bigger clap for Dr. Isaac. He has labored through hypertension, and I think he has put out a good message at the right time. We needed to utilize the essential medicines list and the UCG when we are planning for NCD products. Let me not only talk about hypertension. The UCG changed in 2023, but the molecules that we find in the health facilities are the ones that are unwanted. And we are about to plan for medicines between December and I think by February. So the DHOs and all of the people who are here who support facilities, let us plan for the right medicines, because we are ready to treat NCD patients better. Now that we have listened to the brother and the sister, because we don't know whether diabetes is the brother of hypertension, we don't know which one is the sister, but we know that they are relatives. Diabetes and hypertension are purely relatives, and that's the message you need to know. Where you see diabetes, be careful about hypertension. We also know that kidney disease is a child of diabetes and hypertension. So at this point in time, I wish to invite Dr. Karye Subira, the physiology man, to come and take us through prevention of kidney disease. I hope you will, since it's a child, you will take as little time as possible.
Thank you very much. I want to stand on the protocol that was established, and I want to thank the organizers for making it possible for us to talk about these issues of non-communicable disease. I'm going to talk about kidney disease and its associated complications. My work has been made easy by the brother and sister, and I don't know, maybe the grandfather who's cancer. And he talked about all the preventive issues. So kidney disease is a very big problem. In fact, until recently, it was left as an orphan. But we thank the World Health Summit that it has now been recognized as one of the major killers. About 850 million are living with it, and 13% in sub-Saharan Africa, much more than, of course, what you've heard before. But the key message here is that 90% of the people living with kidney disease don't know that they have it. That small graph on the left is showing you those statistics. Even the 10% that know, they actually get very poor treatment. When we talk about kidney disease, it's very hard to know, but we characterize it as acute kidney injury, acute kidney disease, which ultimately becomes chronic kidney disease after about 3 months. So this actually shows us that we have a lot of room for intervention if we discover kidney disease much earlier. If you don't, you actually end up on dialysis and ultimately in the grave. We have done some studies for Uganda, and we know that kidney disease prevalence is between 3.9 and 12.5%, and there are regions that we have not done community studies. But from the map that was shown by Dr. Senabulia, you could probably infer that in the north is going to be a little less. But we have also done studies in the community, and I've looked at if a person has an abnormal creatinine, what happens to them? This is published work. We did it in Chamulibwa, and it shows that once your creatinine is up and your GFR falls below 45, your risk of dying within 5 years is actually 6 times. So kidney disease is not innocent. We've also done some work in hospitals. This was work done by one of our postgraduates. What we found was that 52% of the people who come to the Mulago Clinic already have kidney failure, which is stage 5 kidney disease, and they will need dialysis or transplant to live. And when we looked at data over a 4-year period, on the people who got admitted in Mulago Hospital, those graphs are quite busy. But we showed that actually the infectious diseases were quite coming down, but the non-communicable diseases were increasing. And hypertension, of course, diabetes were in the lead. But kidney disease was again among the top 10 causes of death among those who got admitted. Of course, when it comes to treatment, our access to treatment, although the Ministry of Health and the government has tried to spread it, our access to treatment is very abysmal. In fact, before 2019, people had to travel 300 kilometers to come to Kampala for dialysis. We've now tried to act upon this, but the units are still very few. Now, the challenge comes when you get kidney disease. It's actually very expensive to treat kidney disease. You probably need, when we have kidney disease, you need dialysis, and that dialysis, you need a catheter placed in you, and it's at a cost, even when you are in the government, and then you need to do this dialysis for the rest of your life. You need to do dialysis 3 times a week, and in private, it's about 400K, so that means you need about 1.5 million every week. And then if you are in Mulago, you need about 600 every week, and that's the cheapest. And to help facilitate this, to make you understand, the doctor's salary in Uganda would not make him afford dialysis, the medical officer. So you can figure out the rest. So what can we do? I thought that we need to take responsibility at individual level, community level, and then our government at the policy level. So at the individual level, you have to take responsibility and understand that kidney disease is most times asymptomatic. So you need to screen your urine and a creatinine test whenever you are above 40 years. And once you discover that you are at risk, which most of us are, you have to do self-management. Dr. Noreb talked about all those things. I won't belabor that. And when you are found sick, make sure when you are given these medications, you adhere to them. And then you do the monitoring. In our development of guidelines, we actually developed a good chart. I think Dr. Mugabe, you have not seen it, but when we presented, we've actually unfolded that thing, which you can just display in the community and people know. So at the community level, the government has actually trained community health extension workers, and these are able to screen the blood pressure. They can actually also screen diabetes, and those should be used. And then we have support service counseling. This should be established so that we have peer individuals who are going to be talking about these problems, particularly the diabetes and hypertension, and subsequently the kidney disease. But we can also have enablers, like Rumu has talked about task shifting. We need to have decision support. These days, you don't need to go to Kabera Maido. You can actually remain in Kampala and do teleconferencing. Then we come to the policymakers. They actually need to do a good framework to secure funding, develop the guidelines, and build the service capacity. We currently have only 14 nephrologists, so we probably are going to need more physicians and other people trained for task shifting. But once the workforce is also in place, we need these people trained, supervised, and we have just done 12 transplants in Uganda, so we have the capacity to do this, but we need to be financed. Now, to crown it up, we have developed the guidelines. These are the integrated kidney disease management guidelines, and they have been developed in collaboration with the Ministry of Health. They are quite unique because they are whole-embracing, they cater to risk factors, and we have scheduled them in such a way that at every level, from the community to the health center one, up to the National Referral Hospital, everyone has something they can do, including guidance on dialysis and transplant. So, in summary, I've told you that kidney disease is very common and is associated with high mortality, and the majority of the people who have it don't know. We are currently developing guidelines in Uganda, and it's important that we appreciate the people at risk and try to look out for them. Thank you very much for listening.
Another bigger clap for Dr. Kariye Subura. Yeah, indeed, it's true. We have kidney guidelines. They were approved by top management, Ministry of Health, and they are due for dissemination. At this juncture, you know, clinically, when you stop breathing, you have died, isn't it? Even in my village, there is a way they can tell that so and so has died. They bring some piece of cotton and put around the nose, and if they don't see it, do like this. then they will say, you don't need to take him to hospital. Now there are these important organs, the lungs. Because they are like guarding the heart, we think they are not important. I don't know why they guard the heart. But actually, at times you cannot know whether the lungs or the heart is more important. It's a question that we can debate. We have these conditions. At times when you want something, you want to do it quick. With the lungs, once something is very fast, it is not good. If it is very slow, still it's not good. So I wish to invite Dr. Katajira from Makerere Lung Institute. Those of you who don't know Makerere Lung Institute, they have helped the country in revolutionizing lung health. We wish that they could work with the regional referral hospitals, because I still see some directors here. Because lung health and lung care, I can truly tell you that it is not very proper, even in our regional referral hospitals. Katajira, you can speak.
Thank you so much, Dr. Frank. Good evening, ladies and gentlemen. All protocol observed. The lungs tend to be a bit standalone. They are very distant relatives to the kidneys and to diabetes. Sometimes they are the mother, the father, the grandfather, and also the distant grandfather, as we are going to see. So I have a daunting task of summarizing this within the minutes allocated to me, and I'm going to try to do that. So by way of background, in tourism, we hear about the big five, that when you go to a national park, look for a lion, look for a leopard, and then look for the animals they eat: the buffalo, the rhino, and the elephant. Those are the big five in tourism. Likewise, in lungs, we have the big five lung diseases that are responsible for most clinical consultations and most deaths worldwide. So we also did studies here in Uganda to see if actually the trend is similar. And not surprising, they are still there. Asthma, COPD, pneumonia, TB, and lung cancer. COVID somehow came in a few years ago and confused the whole picture, because somehow everyone who came in was attributing their problems to when they suffered COVID. So COVID just came in as a confuser, but the main big ones are five. If I'm to rank for you, asthma is by far the commonest. We did a study, and we actually found that about 11.1% of Ugandans have asthma. That is the average prevalence. The lion's share is in Kampala and other urban centers, where the prevalence stands about 14. Now, you need to appreciate that this was a study, meaning that we were very conservative in the diagnosis. So meaning that at the time of the survey, if you didn't meet the criteria, we didn't regard you as having asthma. But I will tell you that the picture is much worse. So by just statistics in this room, everyone here knows someone who struggles to breathe, and we'll be finding out why that is the case. And then we have COPD, which tends to be confused a lot, especially because it doesn't have a local terminology. Even in Uganda, there's no term that actually will refer to COPD. Pneumonia is another story. It's one of the most abused diagnoses. I think patients will come in. Any cough, basically in Uganda, will be labeled as pneumonia. So much that even patients know that it is called, actually for them, they don't call it pneumonia, they call it pneumonia. They come in saying, they told me I have pneumonia. So you just know. And most of those actually will end up having either asthma and COPD. Now, TB is another one. It was in the past regarded as an infectious disease, but we are seeing a number of patients with what we call post-TB lung disease. appreciating the fact that when TB comes and it causes damage to the lungs, that damage is lasting, it is permanent. And because of that, patients tend to come in with lungs that are a bit less than when they started TB treatment. And interestingly, as I've told you, that some of these diseases are the fathers and the parents, most of the patients with post-TB lung disease actually tend to have post-TB asthma and post-TB COPD. So you really find that TB is a leading cause of COPD in Uganda. Because smoking, as you can imagine, we are not a smoking country. And in fact, even for lung cancer, the studies we've done are a bit shocking. Most of our lung cancer is in non-smokers. So we still wonder what is driving lung cancer in this country. Now, just to summarize a little bit of what these organs are, the lungs, they are basically made of two parts, the pipes and the sponge. The pipes have a very simple task. When you breathe in air, those pipes just move that air into where the sponge is, because that's where the magic happens. And once the sponge has done its job, it returns back that air into the pipes and you breathe it out. So sometimes you'll have problems in the pipes, other times you'll have problems in the sponge. And many times patients get confused because when you tell them that you have problems with the pipes, they ask you, so are my lungs okay? And this is just really, again, to drive the point home that the lungs are both the pipes and the sponge, okay? So you can see those colored dots. Those colored dots basically are the air that you breathe. And you're going to be talking about air a lot. And you'll probably appreciate why. Now, when you look at these lungs here, to prevent their development, you can classify them into primary, secondary, and tertiary. Primary is really doing things to make sure that you don't develop the lung disease. And among these, we have things like reducing the exposures, including air pollution. We are going to spend some bit of time on that, reducing open burning, occupational exposures, and then generally awareness. Why do we want to make sure we don't go to secondary and tertiary? Because lungs are extremely expensive to manage, extremely expensive. And even when we drafted guidelines, for the new clinical guidelines, we would have collapsed the health budget. Why? Because, for example, the diagnostic screening, spirometry, it's a very expensive test. And without it, you cannot diagnose COPD. You just can't. We've tried to put together questionnaires. They still do not tell you if someone has COPD. Because again, especially in our country, remember I told you the mother and the father. Let me take a little bit on that. Besides TB, the other leading cause of COPD in this country is poorly treated asthma. So you can actually see how all the arrows end up leading to one place. So poorly treated asthma leads to COPD. TB leads to asthma and COPD. So you find the child, the grandparents, and the parents are all on the same slide, okay? So now, going back to primary prevention, we try to make sure, on top of all the things that you've had, good nutrition, exercises, those are very good for the lungs. We also want to mind the air that you breathe, because most of the interaction that happens with your lungs comes from the environment. And we're going again to appreciate that. So like I said, the screening tests are extremely expensive. When you talk about symptom screening, you will have left out the men, because men don't feel symptoms. There are only 3 reasons men come to hospital. Number 1, if the woman in their lives insists that they should come to hospital. Number 2, if the symptoms they are having are interfering with their productivity. If they are, for example, public speakers and every time they speak they cough, they'll come to hospital. But as long as they can move to the hospital, to their workplaces, they will not come to hospital. Number 3, if whatever it is that is affecting them is affecting their manhood, they'll be at the hospital at 5 a.m. in the morning. Besides that, you don't see them in hospital. So when you do symptom screening, you will have left out the men. Most of them come very, very late in their disease. And usually when they come late, then we go down to the tertiary prevention, which is again extremely expensive. So we want to measure on the primary prevention. And here is why. Now, an average adult breathes in on average 8 liters per hour. When you compute in the 24 hours, you would have breathed in a total of about 11,000 liters. So the next time you pass by that 10,000 liter that you used to collect water, stand next to it because that's the amount of air that you breathe in a single day. So it is extremely important that that air that you breathe is of high quality because whatever that you breathe in will interact directly with your lungs. And this is why we are currently running a social media campaign to raise awareness on the quality of air that we breathe in Kampala. These are pictures that we have been taking on our way to work and on our way back home. These are things that we have not been paying attention to because when you're driving to work, you're looking forward to the next car you want to overtake so that you reach work as soon as possible. So we tend to miss out on what is happening around us. But actually what is happening is that you pass very early. These are all pictures taken very, very early in the morning, between 5:30 in the morning to 7 a.m. And you pass people who are burning rubbish and tires openly. You are passing tires. I think you can see that in all of these, they actually are around human beings. You see that taxi and the man who is walking by the taxi, and they are inhaling all the exhaust fumes. Then you see this lady walking to work, and they are inhaling all those fumes. There's another corner there, roadside cooking. It is happening along the roads, but we are just too busy heading to work. So by the end of the day, by the time you reach work, the amount of pollutants you will have breathed in are just unacceptable. Now, ask anyone who struggles a little bit with breathing. They will tell you that they hate the rush hour because that's when the quality of air is at its worst. Now, sometimes when, that one is actually an interesting one. Burning bricks. If I told you where this was, you would think I'm lying. In the middle, on the main road in Kampala, you will not even believe if I told you where that was. But they are burning bricks. We probably would have passed that in the morning until we started this campaign of taking pictures of actually what is around the environment we interact with as we go to work. Most of these patients, if they are asthmatic, if they have COPD, by the time they reach office, they are going to hospital. They are consuming resources because of the quality of air that we are breathing in. So it matters very, very importantly that we breathe in pure air. Because when you look at every risk in lung disease, even if it's your personal exposure, you have to multiply it with the risk, which is the environment that you breathe in. That environment is the air that you breathe. There is an app, for example. So there's a group of Americans. This year, they came up with some bit of modeling. And they estimated that breathing in air that is equivalent to 22, it's 22 micro, those units. It's called the air quality index. That every time you breathe in that air, it is equivalent to smoking 1 stick of cigarettes. So I just tapped in here in the app called AirCore. I tapped in Perere to just see the quality there. And it was standing at about 57.5. Those are equivalent to 2.5 sticks of cigarettes. So these Americans are saying that it's actually possible that in your work environment, you breathe in or you breathe in air that is equivalent to 1 pack of smoking per day. We don't know what that means yet. We don't know whether that might explain all the cancers that we're seeing, but we know one thing for sure, they are going to exacerbate every airway disease that we have. So in conclusion, we have to lobby more. Probably the cheapest that we can concentrate on here is primary prevention. Oops, where is that? Primary prevention. Trying to make sure that, unfortunately, when it comes to ambient air pollution, there isn't any research-proven methods that can improve the quality of air that you breathe in. The closest is a mask which is well fitted and it is filtering everything, which is extremely difficult. For some people, they'll not be able to breathe in that. Besides that, there are very, very, very few methods that have been shown to work, apart from taking cleaner routes, avoiding the congested places and just driving on the open ones. The ambient air pollution interventions are very limited. For indoor, we can talk about pressure cookers, we can talk about microwaves, we can talk about all those things, and everyone here maybe in this room can afford. But the one thing that we will all be exposed to at some point in our lives is the quality of air that we breathe in when we get out of this place. So that's why it is probably the hanging fruit that we can control to find a way of reducing what we actually are seeing as the increase. So for example, every time it is dry weather, we know our clinics are going to be very busy because of the asthma attacks that are going to be coming up. So I'll end there and thank the organizers for this.
A big clap for Dr. Katajira. The quality of air that we breathe. How do we stop it? How do we stop Kampala from becoming what we have seen on the screen? Because if you go out, as you go home, just look around. Kampala is covered by smoke every evening. How do we stop that? That is the question. And we have a lot of asthma. We have a lot of COPD. The other day when I came with my mother to Kampala, she came with no cough. But when we reached Kampala, she had a cough. And I blamed the pollution. Yeah, she told me I was with her in the village, she was not coughing. We drove to Kampala, the next morning she was coughing. I definitely knew that I'd brought her to a dirty environment. I kept quiet, I said, let's wait and see. But this is the situation we are in. He has not talked about killing. Respiratory conditions kill about 2 million globally. I don't know how many in Uganda, but they really kill. Now, last but not least, NCD lab diagnostics. I don't know how to describe the lab, but I've seen in the communicable world of diseases, because I was there, the automation of diagnostics, there is a way it changed things. I think if there is any section that has developed in terms of medicine, I think the lab is one of them. So we from the NCD world, we are also eager. Of course, there are some products that we have which have not reached where I want them to reach, but we're also eager to learn of how the lab is integrating, including NCDs. Allow me to invite my boss, Dr. Susan Nabada, to take us.
Thank you so much, moderator. I know I'm coming in at the end, so I'll keep it short. And you've made my work easier, so they've described everything, what the NCDs are. I'm just going, and they've been listing that diagnostic tests that we need. So I'm just going to show you what we have in the country. So all this has been talked about. But in Uganda, our main priority diseases are cardiovascular diseases, metabolic diabetes, chronic diseases, chronic respiratory diseases, cancer. And I felt that already one of them was discussed yesterday. That was the sickle cell disease, the hemoglobinopathies. And today's session was mainly focusing on those four. But in Uganda, we've started seeing that most people die because of the risks that they have for NCDs. 22% risk of premature death is mainly because of the NCDs between 30 and 70 years. But we've noted that these remain undiagnosed because we've noted that results, the many patients seeking care only come after complications, as we've already had. And as our moderator has said, over years, we have built massive capacity in the lab, massive investments in the lab to support the other communicable diseases, TB, HIV, malaria. But I'm glad where we stand now, that with all this investment and this conference that has brought us together, we're going to see how we can leverage on this massive investment that has been built in the country on the side of the communicable diseases, TB, HIV, malaria, and the epidemics that we have, COVID, Ebola. How are we going to use that capacity to support the non-communicable diseases? We've noted that we have statistics now, and we are asking, is it that we are having increase in these NCDs, or they've been there and there is something that is happening? We think that we have had lifestyle and epidemiological shifts that has led to the rise in the risk factors, the high blood sugar, the overweight. The way we live maybe has caused the increase in these NCDs. But more so, we've also noted that we have improved lab capacity and availability of screening tools. You've heard that now, as I'll show you, how we have availability of these tools, the glucometers, the screening panels, the biomarkers, which identify conditions that were previously underdiagnosed. So these are some of the things that are maybe making us realize that we have an increase in NCDs. But also the policy shifts now. I'm happy to note that almost every disease here has a guideline, has a governing structure, it's all well stipulated in the UCG guidelines. These have also streamlined to show that, and maybe this is leading to making sure that we are seeing more NCDs coming in, the prevalence. So the governance and the guidelines have also streamlined these things to make sure that we can be able to tackle NCDs. But of recent, we've also noted that the way we are delivering our services in an integrated care model, we've leveraged on the health investments to show that, to be able to incorporate NCDs. For example, in the HIV program, we've currently seen how we've incorporated making sure we do diabetes screening, hypertension, mental health. In this way, we are noticing more because of the changes in shifts of the way things are being done. So how are diagnostics in healthcare supporting NCDs? They've already been talked about, how they support NCDs, but mainly they help us in making sure that we accurately detect the disease. Accurate detection, but after detecting, they've been telling us they use diagnostics to manage, to monitor, to prognosticate, but also to have to draw a roadmap for the patients. So it's a very critical intervention, and we all know that whatever they've said, you've heard that they will not know that whether it's respiratory or diabetes or kidney before having a diagnostic test. So we need it for early detection, for informed decision-making of treatment, for personalized medicine. Where we are now, we are really using diagnostics for personalized medicine. Cancer, Dr. Noleb talked about this. It's no longer a matter of saying you have breast cancer. We need to know which markers. We've even gone beyond just knowing which receptors. Now we want to detect which particular mutation you have, because now the pharmaceuticals are making targeted treatment, and this will help in improving patient care. But this cannot happen if we can't support it on the side of diagnostics. So where we are getting into personalized medicine and targeted therapy. All this is in line with the diagnostics to support NCDs. And how do we do the diagnostic approaches for NCDs? Already talked about the screening programs. That's the entry point. You can have the targeted one for specific populations using the different diagnostic tools, mammograms, colonoscopy, name it as they've been talking about it. But also targeted interventions of making sure if you have a patient at risk, please make sure you screen them for NCDs. If someone walks in and has obesity, Don't just treat her or his malaria because he has come in with a fever. Go beyond, because this is a risk factor. We can also at the same time use the screening and applying the diagnostic tools in the context of care. The other thing that we use in diagnostics, as Noleb has said, is around biomarkers that predict the disease risk. They guide treatment, they can monitor. You've heard about all these things like go and do your PSA, your CEA, your CA125. I want also to emphasize that these are not diagnostic tests. They just help you screen and know that maybe there's something happening, go further and look out for it. And having no raised markers doesn't mean you don't have the cancer. So we've seen people coming in and like, but my CEA is normal, but they are telling me I have colon cancer. So we need to interpret these biomarkers in line with that. And right now, with advances in technology, we've even, instead of waiting to get the biopsy to be picked off, we have what we call a liquid biopsy. Instead of taking that tissue, we know there are circulating tumor cells in blood. We take it off, we do genomics on it and see, and then we can make a diagnosis. So we are advancing beyond to be able to support the diagnosis of these NCDs. We also know that we can't have all these capacities in one place, but yet we can be able to access them, as you shall see in my next slides. So we've also advanced in terms of making sure we can support diagnosis at afar through teleradiology, telepathology. I can be here and I read a slide that has been prepared maybe by a colleague in Moroto, and then I can give a result. Or we can have an X-ray or an MRI done by a person in Arua, and Mulago reads it. So all these are advances to make sure that we increase access, to make sure we can diagnose NCDs. So what is happening right now in Uganda? Do we have all these? Are we able to support that clinicians to make sure they do the diagnostics? Yes, we can, but not everything, but at least we have a network. Right from the national reference labs that we have almost 11, to the regional hospitals almost 17, to the general hospitals up to health center 3. We've established laboratories. But as we also speak now, the lab has gone outside the buildings. We are now in the community, and they've already talked about the CHOOS. That's also another arm that we are using. So across all this network, we also don't work alone in the public setting, but we also use capacities in the research institutes, in the academic institutes, to help us do some of the diagnosis, but also the research that informs care. You've heard all the research done by Lung Institute, by Makerere. They are now translating it to be able to support in making guidelines. So we don't work in isolation. So, but in the public setting, what is the capacity we have to support? Right from the region, from the national hospital, the national reference labs that are 11, to the lower health facility, and then to the community, we have distributed and make sure that we have capacity to be able to tackle communicable and non-communicable diseases. For example, in the whole network, we have over, actually it's not 200, we have around 398 gene experts across the network. And these gene expert machines are able to do, I'm just bringing in the infectious part, because we've seen some of the NCDs are driven by infection. So we are able to detect this. We have gene experts distributed all over to be able to diagnose TB, but now it's no longer TB machine. We can be able to do other things like viral load, HIV, HPV testing for cancer. So we are integrating in into the communicable disease platforms to be able to do NCD diagnosis. Across all health facilities up to Health Center 4, we are able to do chemistries for the kidney and the diabetes, chemistries and hematologies at different levels of care. We are able to measure our hemoglobin across up to the lowest level of care. We have glucometers, as I'll show you. If you look at this particular, and you see the level of care, if you look up to Health Center 3, you look at chemistry, hematology, blood glucose, sickle cell. At least we've distributed up to the lowest level of care. That's Health Center 3. All the regional hospitals are able to do the basic tests that are needed to be able to diagnose NCDs. And in our national reference labs, we have high throughput equipment that can be able to do molecular testing to support NCD testing, genomics, but we are integrating and leveraging on all these equipment we are set up and brought in for infectious diseases, but they can be able to multiplex and multi-disease test to support NCD testing. So we are doing a lot of genomics to support cancer. We are doing molecular testing to support other diseases, NCDs. So at least there's capacity in terms of skilled laborers, competent staff, together with the equipment. So these are the different capacities we have at the different, to do full blood count up to the lowest level of Health Center 4, and we are trying to equip up to Health Center 3, and capacities to do RFTs and LFTs that are really needed, and lipid profile, and we are able to quantify, and we have guidelines that guide this. So capacity for equipment is there. The biggest issue is reagents right now. On the side of diagnosis of cancer, is still a big problem in terms of HRH, in terms of the number of labs that we have, because most labs we have are they are in academia and a few in the public setting. But as we speak now, through Ministry of Health support, I think they are going to establish another 4 to support anatomic pathology testing, to be able to support the diagnosis of cancer, most especially. But since we don't have capacity everywhere, the ministry saw it right to set up, out of the 1,500 labs that we have, we decided to make 100 labs well equipped with reagents, with equipment, with HR, to be able to support the spokes that are around them that cannot do these tests. For example, if I have an HPV test to be done in a lower facility, it will be transported to the hub that has capacity to be able to do this HPV test. So we are using a lot of sample transportation to increase access for NCD testing. Even sugar, even LFTs, RFTs for facilities where we haven't reached, we are able to transport. So let's not say I cannot take off a sample because I don't have capacity, because there's a system to transport to the areas that have the capacities. And diagnostics is not only lab, also on the side of imaging. We've noted how imaging is very important. We need to have, we've also built capacity, but we know imaging helps us to detect, diagnose also, and stage. You've heard, especially more in cancer, in the lung diseases, where we need imaging, ultrasound, CT, MRI, mammography, to support the detection and diagnosis and the monitoring. So what do we have as a country? We've moved as a big step. We have over 570 X-rays. We have over 21 C-arms. We are able to do mammography in 19 facilities. We have over 10 MRI scans to be able to support monitoring and diagnosis. As we speak, and I'm glad the regional referral directors are here, we have 14 CT scans across the country. All the regional hospitals have, and they are fully functional. We have MRIs because that's what you need to use. We have X-rays. And now we've set up a teleradiology center such that in case you have a tumor and you are in upcountry and you want to be supported in interpretation, there's a teleradiology center in Mulago equipped with consultants that are able to support this. So we've also grown on the side of imaging. And as I've said that it really helps us to be able to diagnose early, because we know that the more we delay, the more we come with late stage disease, poor prognosis, and then we shall have big costs on management of these patients. So that in addressing NCDs, diagnostics at the center. We have the capacities in terms of the equipment, in terms of the human resource. But the biggest challenge, and as we sit here together, as we advocate for reagents for communicable diseases, since we are in a unified action, let us advocate for reagents for non-communicable diseases, because the platforms and the infrastructure we have set up is able to support NCD diagnostics and monitoring. So wherever you are, please advocate, from the CSOs to our partners to academia and the ministry, as we continue to lobby, because we've seen they are very, very important to have diagnostics to manage. Capacities are there, but lack of reagents. But thank you so much for inviting me to talk about the capacities we have for diagnostics for NCDs, and we can continue with discussions and future collaborations to make sure that we take NCDs to the level where the communicable diseases are in terms of diagnostics. Thank you so much.
How can someone assure you that capacities are there and you clap like that? Capacities are there, but reagents, can we plan for reagents, ladies and gentlemen? It's true, capacity is there, but reagents. So let us prioritize reagents in our next plans. The presentations are done. In the interest of time, we are going to allow a few burning questions. I want to thank you for your persistence. I've done a random count. We still have more than 100 people in this hall, which is really very good. To me, it shows interest. Therefore, it would be unfair for us to dismiss you without you firing back. So now it's your opportunity to fire back. We may allow about 6 questions. Yes, 6. Members, put up your hands. You help me move the mic. And please. The hands are up. I see hands. If you want to ask a question, put up your hand. And please go ahead.
Thank you. Those have been really good, interesting presentations. This goes to Dr. Sinavulia. As you see the trends in the modifiable factors, that is lifestyle, how have you taken this to the next level? Because we are seeing urbanization taking over our people to be hypertensive. And I really like this goes to Dr. Susan. You've talked about precision medicine. On average, do we have this data available and we see which drugs are really not working on Ugandans and that is working to Ugandans? Thank you.
Yes. Hello? Hello? Yes, greetings. This is Dr. Kabona Anna. I would like to thank the presenters for the good work that they have done and for the informative discussions that have been had. I have a few questions and comments. The first one is on adherence to medication. Majority of the studies that have been done both in Uganda and outside the country, both in hypertension and DM, one of the biggest challenges that we've had is adherence to medication. And as someone from a public facility, that has been a very big issue, especially for patients who have hypertension. You'll find that they only take the medication when they're symptomatic. Then you do the patient education. After a few months, they tell you the same thing, that they are not taking their medication. So it becomes a very big cycle. They only take when they are not feeling well. And that has been a challenge, especially when you're close to the patients, because then they are able to tell you, to disclose very comfortably that, doctor, I'm not taking the medication, I don't feel sick. Then you counsel them. They take for a few months and then they go back. So it is a very big challenge. Then the other one is on counseling as a whole. In terms of, I've looked at the different guidelines, and when it comes to counseling and mental health, these are chronic diseases. And most of the guidelines do not really emphasize the need for counseling, the need for mental health when it comes to non-communicable diseases, because someone is having this disease for a very long time, they're having it for a lifetime. But if we can borrow a leaf from HIV, where they're doing the counseling almost in a periodic manner, it can be a bit better. Then, okay, I'm going to save due to time, but the last one is on the herbalists, the traditional medication. As we've seen on media, several media platforms, you'll find that they advertise freely, and most of our patients, they're very gullible, they are desperate. They want a cure, and the cure is not there. So is it really time for us to start bringing maybe these people on board to see what the best solution is? Because the only thing you can do is just to tell your patients that these are not regulated, they don't have proper dosage, but it's still a very big challenge, especially when it comes to NCDs. Yes, thank you.
Thank you. We are still this side. There are 3 more hands here.
Thank you.
Try to be brief with your questions, please.
I will speak less than a minute. My name is Stefan Kalesula. I have a direct question. I hope it won't be subjected to a consultation fee. That is to Dr. Mugisha. Speak about the saunas. What effect do they have? I know this can go to also the consultant in cardiologist and also Dr. Katajira. What could be the effect to this? And then to Dr. Kajira, the PM 2.5, the particulate matter. The current research shows that it is one of the leading factor in respiratory related infections. Do we have numbers to this in your institute? Probably. Thank you.
Doctor, it will be an injustice. I've been moving this microphone since morning if I leave without asking. I'll ask a question to Doctor who presented about cancers. You described very well how cancer treatment is. Very briefly, what is the cost of treatment and how can this treatment be integrated in the community levels where people can easily reach? Thank you.
Can you give the mic?
Yeah. My name is Miti. I come from a gold mining area. Now, the people there believe, actually 20% of the patients with the TB in Kasanda are gold miners, but 50% have difficulties in breathing and 5% cannot breathe on their own without support. They believe that it is the ghosts in the mine are the ones which are annoyed and because of taking their gold. At the same time, the gold miners don't allow us to access the mines to talk to these people. Now, you as a lung specialist, how can you help me in terms of prevention and management? Then the other, I'm calling upon you to come to Mubende. At least this is an area of research maybe we can get something to inform the decision makers and perhaps the community. Thank you.
And tell us whether they are really ghosts or not. Because I think they are not. Yes, there is a hand that has remained persistent there. Please let's pick those two hands.
Thank you so much to the panelists. My question goes to Dr. Nobel. First of all, you told us to go to the health workers. Doctor, I want to tell you something. I read an article in Daily Monitor recently, and it was about a lady that had battled with cervical cancer for the last 7 years. And yes, yet they persistently went to the health facility, and they were told they had candida for the last 7 years. And I can imagine what stage they went, by the time they went to the Cancer Institute, what stage they were at. And for that matter, I want to ask you about misdiagnosis. One of the factors a previous speaker yesterday talked about that is contributing to the increasing numbers of late diagnosis. I want you to talk about it and what the Uganda Cancer Institute has done about it. And then also in the quest for awareness for maybe the ladies or everyone should go and screen about cervical cancers. I want to ask on that matter about the outreaches. Are they being done, and what procedure is followed to do an outreach in Koboko, an outreach in Tungamo district, so that people do not just wait to come to Kampala from Tungamo, from Koboko, and by the time they come here, they're already at late stage cancer, whatever. So maybe that's what I want to ask. Thank you so much.
So I want to add something on that question. Where are cervical cancer screening services in the country? There is a hand.
Doctor, I thought I'm the one on. Can I speak? He comes next, because.
Please go ahead. The one.
Thank you,
Thank
Doctor.
you so much.
Emmanuel Sempala Kaohoima. I wanted to ask Dr. Senabulia, is hypertension reversible? And in case my BP is normal, 80 to 120, do I switch off the drugs? And I practice exercise and dieting, all that. I wanted to request the organizers, is it possible to give us contacts of those consultants that we can consult at a personal level in case we want? Like these lecturers who are here from Mbarara, they presented well, we could consult more. And you doctors, since we have the access now and we are interacting freely. Thank you very much.
Message taken. Yes, go ahead, please.
Thank you so much. My first observation is we all look to be candidates of the NCDs, especially the environment.
You don't look who you are.
Aha. Now, I'm asking a very small question here. We all light charcoal stove. It has been disturbing my mind, that smoke which comes out. And our shelter, they are so squeezed. Most of us staying in urban areas. How best are we going to educate our community? Because that is something becoming traditional, but exposing all of us. Secondly, when are we equipping the CHOs to do the community screening? Because I've been interacting with many in health facilities, they don't have those equipments. My question comes, when are we equipping the CHOs so that they also contribute to that very important aspect of screening at community level? Thank you, I submit.
Thank you very much. My friend Frank there has a question. Please give him a mic, he might hate me.
Okay. Thank you very much. I'm Mr. Kalyango Frank. I'm the NCD focal person for Wachiso District. I'm also a lecturer of non-communicable diseases with Victoria University. When you look at the themes that were cross-cutting with all our very good consultants, the issue was prevention. So and when I interacted with the commissioner, the issue was self-care. Ministry is having that initiative. So I'm just making a request to the panelists. What is that thing in prevention that you want us to leave with as the key message from each person? Thank you.
How many more questions?
Now the last hand, the other gentleman down, in the interest of time. So that one.
Thank you so much. Asima Kalemire. I come from a community. Okay, my issue goes to all the panelists. I come from a community of which is having a problem of the neglected tropical diseases, and that is from COMMUNICABLE district, and the sub-county that is affected more is Busiriba sub-county, and that's where I come from. These patients are affected by whatever we have been discussing, including mental health that we discussed yesterday. The effects that they have has stopped them from going to hospitals. They are not attended to, and they are also persons of concern, and they remain human beings. And I think Dr. Archibald Bahizi can agree with me. How best can we support this group of people that have been, I would say, left out? Thank you so much.
Thank you. We are extending to 2 more questions. My senior Maya is there. I found him in the ministry.
I can even sack you. But anyway, thank you. I think it's my gut feeling that we could be talking to ourselves as academicians, researchers, physicians, and so on. Right from the time Barara University presented to now, we are basically glossing over disease that could be prevented to save the wananchi in this country. It's my recommendation, therefore, Chair, that right now it may not be an easy time, but I think after elections, we present all diseases right from Barara University when it presented to now, even yesterday, including the asthmatics and the sickle cell disease, that we present to the new government to deal with this situation. To ourselves, we're asking, how do we are looking at a local level, but at a higher level, I think we can do a lot. So it's my recommendation that we present these diseases to the next government that comes in after January as part of the recommendation, because we may be talking to ourselves here now, but there is a lot more, because these are preventable, they are curable, but I think we will be doing little, and most of our members of parliament may not know. So it's my prayer that we take this to the next government that comes in after January. Over to you, Chair.
Thank you very much. The recommendation is noted.
Thank you very much. First of all, I want to thank everybody. I'm Matthias from Namaingo. One thing that I've seen is that you now need to propose a policy reform such that these hospitals, both regional, national, they should be reorganized, and we have NCDs under one command, under one leadership. One of those could be leading the others, and there they would be operating very well. Amidst them, we shall also need a physician to organize the setup with professional counselors. The other thing that I want to say is that information centers and these hospitals are training units. We have a challenge that these officers with their interns, or those who go there for training, they seem to stand independently. And when they come down to work, they don't look at this as one unit. And the worst still is that many of the officers think that solutions are supposed to be at higher levels of service delivery. Yet we need them to do similar things at lower levels. And for that reason, at OPD, many medical officers don't want to be at OPD, by the way. And yet that's where they're supposed to be doing the really clinical, the really issues, and also governance and leadership to ensure that the system is well set to appreciate these small things because they make a difference. Thank you very much.
Thank you. We are only going to take this lady. Please bear with me. Allen, ask tomorrow.
Yes, my question
We are
goes
still
to
here.
goes
Please
to
go
Dr.
ahead.
Senabulia. Of course, the gentlemen have not represented us, the mothers, very well, because these days the major cause of deaths among women or mothers is eclampsia. So many women die because of that, or their children, especially young women. So we need more details about what causes it and how we can prevent it. Thank you.
Okay, I hope Dr. Isaac can say something, but I'm sure there should be a session in the conference in reproductive health. I'll give my panelists 2 minutes each to respond to some of the issues that were raised concerning you, starting from Susan here.
Thank you so much for the questions. About the choose, yeah, we've taken the lab to the community and we are working closely with the health promotions department to make sure they are well trained, because even that result down there should be of a quality result. So we are going slowly. The only diagnostics they have now is they do the BP and the glucose measuring, but we are going to train them to do more in rapid diagnostic tests like malaria, sickle cell, lipid testing, but we are going slowly because we really need to train them so that they are able to test right and also troubleshoot. But it's the way to go, and we are going to keep on increasing the scope of the tests they are doing as we keep monitoring them. About the precision medicine, we don't have data yet. We have the capacities to do that, but as I said, the reagents, but for those that are able to do via research, those people who can pay privately, they are actually doing it, because on the side of care, you see they've super specialized. We have to match the specialty they have to be able to do that test. They want to treat patients when they know exactly what they want to treat, but on our side, we've not yet got the reagents to be able to do that, but so we don't have data on the public side, but people are actually doing these tests in the private setting and also moving abroad. But slowly, and as we continue lobbying and getting resources, we will be able to collect all this data. Thank you.
Thank you so much. Quite a number of questions came in, but I'll tackle, I think, 3. Lifestyle, we have to be exemplary. How I simplify it to my patients, what works for me, I give them. And then when I hear what works for them, I consolidate and I utilize, then I give back. So it should be a personalized and an experiential experience. So grow those nakati, you walk, you dig, don't sit a lot. Because if you not doing it, it's very hard to help them do what they need to do. But it's personalized. Let your children actually get it from you and you inculcate it. There are school programs that are ongoing. Sometimes when I go to the city over the weekend, some streets are closed to encourage us to walk. So many things we can do. I can't exhaust in this meeting, but let's think about them and implement at whatever level you can do something. The question about hypertension, can it be reversed? The answer is yes and no. Yes, if we know what has caused it. Interestingly, many people are stressed, they're worked up. For example, if you have a bad investment and you lose 200 million, that thing can cause hypertension, meaning that if you overcome that loan, the numbers will get better. But before they get better, we'll put you on medication. And I teach people even at lower centers. I tell them, we used to do chemistry, what we call titration. When that color changes, they were telling us, even in real life, that was a concept they were trying to show us. So even as you're managing hypertension, you don't write a prescription and then they go forever. The reason why they come back is to follow up. What is this medication doing? Am I controlling? And once it's controlled, observe. If it goes lower, you cut back, you titrate. And the mistake we make is they're on 3 drugs, it becomes normal, you stop. That's not being smart. Take them to 2, observe. Take them to 1, observe. And also look at the other factors that influence what they're going through. Their patients actually have put off medication because we found the root cause, we dealt with it, and then we keep monitoring them. Once you clear them that they are off, don't let them to be on their own. Let them come back. That's why the concept of self-care, self-management comes in handy. And I think I can tackle that comment about they feel okay, they go off medication. Tell them to regularly monitor because hypertension is asymptomatic and therefore the drive should be the numbers. I hope I'm clear on that. The last question was about eclampsia. So eclampsia, I mean, there are lots of literature that postulate what could cause it. So my response is simple. Let us invest in diagnosing it, in detecting it, because it's a medical emergency. And once we pick it, that is high blood pressure, proteinuria, convulsions. Don't waste time to cause a cough and ask, why did it come? The mother will die, the baby will die. Treat them, then when they are sorted, we can now try to find out these other things. Many times we don't know the cause. So the investment should be, pick it early. That's why when they go for maternity visits, a blood pressure is a must. Members from whichever health center you are, make sure that BP machine works in the labor suit. Let that urine dipstick be available. That strip is like 3K. If it means the mother contributing for them to have a dipstick, let it be so. Don't be said, oh, they tell us not to charge patients, they will die. That 3K can save a life altogether. They are convulsing, diazepam is available. Manage them, control the blood pressure, safe delivery. You would have saved a nation collectively because sometimes we get lost in the science, yet the real thing is before us. I submit.
All right, the first was about sauna and lung health. This is a long one. Saunas can improve certain lung conditions, but worsen others. So usually we advise that you work with your doctor, depending on what the condition is. Some people actually can get a very bad asthma attack in saunas. PM 2.5, we know the facts that yes, I think one thing you need to know about 2.5, PM 2.5 is that it does not only affect the lungs, it sneaks into the blood vessels and saturates throughout the entire body. And actually one of the organs that is affected most is the cardiovascular system. So you can predispose someone to stroke, heart attacks, and all those things. So PM 2.5 itself is a systemic disease. It can literally go to in fact, it's now been also associated with dementia. So it's a very, very big thing. How to attribute all these things to PM 2.5 is one of the hardest things that you can do in science because of the very many confounding factors. So every time there's a paper that comes out, people still are debating that how sure are you that it's the PM 2.5. So that's probably where I'll end at that. We still lack data of really clearly linking the health effects of PM 2.5 to what we see as mortality. Though, of course, there are very many association studies that have shown that PM, and I think you see it. There was a report that showed, I think, about 100 million people die, across the world because of air pollution and things like that. So there are all those association studies, but the real ones that mechanistic are still lacking. Gold mining, yes, these patients will get difficult in breathing because during the process of mining gold, they breathe in a lot of dust. That dust contains silica. Silica will go into the lungs and damage the sponge, which I showed you. Damaged sponge due to silica predisposes patients to TB. So you have two things happening, that the patient will get TB, but also the lungs will be so damaged. In fact, at the Lung Institute, you just hear patient from Kasande Mubende, and you can finish the whole story. Gold miner with difficulty in breathing, you do a CT scan and the lungs are badly damaged and all those things. So maybe not ghosts, but it's really because of the damage that they, that they encounter or that they go through as they inhale at Silka. The best thing would be to put on masks that filter all those particles and protect their lungs. I think for lungs and self-care, lungs love fresh air. They hate alcohol. They hate tobacco smoke. So probably that's, and they love exercises. Finished.
Thank you very much. I have many questions, but I will address three. One is the cost of cancer treatment. Different cancers are treated differently. So even if a patient is to pay for their cost, there are some cancers where the entire treatment will cost maybe 100,000. But there are also cancers where single treatment will cost 10 million. But the important fact to note is that the earlier the diagnosis, the cheaper the treatment. And I think Dr. Sinabulia mentioned it. If you diagnose early, even heart disease, you prevent many complications. Misdiagnosis. Misdiagnosis is very common because, as the commissioner said, there is capacity but reagents. So sometimes you have health workers, but the tools to use to make the right diagnosis are not available. But also sometimes the way the entire process is done, we are not able to arrive at the right diagnosis, either the way the sample is collected or the way the sample is preserved or processed. So again, the emphasis is really for us to try to do everything the way we should do it, rather than doing it for the sake of completing the exercise. Outreaches. We do outreaches in different parts of the country, but as you can imagine, only one center may not reach every single village where we want to go. But we have trained health workers at different levels, and we are trying to decentralize cancer care and especially cancer prevention. And so if you reached to us direct, we would actually come to where you want us to come. But also we can advise you where the nearest team that is trained can come. And I want to tell you that screening for cervical cancer is available at every government health facility, I think starting from Health Center 4 upwards, and probably many Health Center 3s. So there is no reason for any Ugandan to say they cannot screen for cancer of the cervix. Completely no reason. And then again, if you're a DHO, you're a CAO, any health facility in your district should be able to provide cancer health education, and some of the screening. Thank you.
Members, we may not answer all of the questions, but they will be answered. I wish to invite Kamara Danair to give us a wrap-up. It's important. I know you have captured some points, but we have also been capturing for you. But we thank you very much. We thank the organizers of this conference. I thank the panelists, because please clap for them. I know there is a lot there. They have traded for them to be here. Some of them have missed consultation fees, which we cannot pay them. I know them. But they are here, and they are very passionate about NCDs. And I really appreciate, because even the time we engaged you was very short. Some of the answers for NCDs will be gotten through integration, if we are genuine with integration. If we are genuine, so that we don't have integration that has some ladders. Please give a summary.
If you're happy and say I am. If you're happy and say I am. You are not happy at all. I want to thank our panelists. They have really done a wonderful work. And of course, before you go, guys, we shall have a group picture for day 2. Please do not go away. So I want to give a brief summary. guest per guest, but I want to begin with Rang Health. Rang Health emphasized on primary prevention, citing that the secondary and tertiary are really expensive. I ran to Dr. Noleb. He really defined cancer, which we all fear, which we said is the grandfather, and of course, kidney disease being a child, to the brother of diabetes and hypertension by Professor Karyasubra. So he emphasized screening, and he said that diet revision, being physically fit, avoiding alcohol screening is very important. Professor William Rumu, he gave us wonderful statistics of diabetes. Friends, the statistics speak volumes, but when you are part or among of them, it's when you pay attention. It's when you lose a relative. When you hear announcements, you are not concerned of other people, but when it's your relative, it's when you feel the urge. And he said that 32% of the newly diagnosed were lean. Their body mass indexes were below 25. So he said for you to be fully diagnosed, you have to be in the health facilities. He gave us key take-home messages that included increasing diabetes screening. And of course, he said that there's no difference between rural and urban settings. Dr. Senaria Isaac, he emphasized the need to ensure we focus on prevention and we guard our hearts. Professor Karyasubra Robert, the father of physiology, he talked about kidney health, and he said that 90%, this was really shocking, of the people in sub-Saharan Africa do not know that they have kidney disease. And of course, it calls us to the prevention which he classified individual, community, and policymakers. But me as a nutritionist, I really want to focus on the individual so that you can practice self-care as we wait for the Ministry of Health to perform policies. Dr. Susan Nabada, the Commissioner for Laboratories, she emphasized that the advanced laboratory technology and imaging has really helped us in identification of diseases, of non-communicable diseases and communicable diseases. And he said that, and she said that, sorry, imaging is very key, which the government has intensified. We have human resources and we are still in need of reagents. Ladies and gentlemen, those are the key points that I was able to capture. On that matter, therefore, I'd like to invite the keynote panelists for a group picture. Then later we can have the last group picture. I want to thank you.
Okay, thank you very much. A round of applause for the whole team. We really appreciate you. Thank you very much for enlightening us. Please, I've been hearing from the team out here, the slides are very beautiful. Please leave them behind if you can. And we'll definitely
have all the slides and we shall take the emails and share.
And also the contacts of the different, you've heard the cow say, the contacts of the different people on those slides. Some people want to do some personal engagement. Dr. Mugabe said that they would be now already somewhere earning some money. This is the first place they can earn money. So thank you very much. Once again, a round of applause for the team. And tomorrow, for the next 3 days, they will be with us. So please do consult them and please make sure that the organizing committee of this conference gets a bit of the percentage of the money you're going to be giving them. Thank you very much. Thank you.
The camera person,
I'm told you're going to take a photograph. We are going to close for now. We are going to arrange this place. But we're also inviting you, for those who can make it at the poolside. We have a small evening together. You can join us for a drink or two, and as well as you prepare to get to your places of residence. Once again, thank you very much. See you tomorrow. The conference begins tomorrow. The conference begins tomorrow at exactly 8:30. Let's be here so that we can have a good time. Thank you. All right. For those who want to take a photograph, please take a photograph and have a nice evening.
Then later, after all this, first take us.
For those that want to join the photo with the experts, please come and join.